Sarah McNab is Head of General Paediatrics at Melbourne Royal Children's Hospital. Please give her a warm welcome.
Hi everyone, I'm Sarah McNab. I am not an expert in this particular topic. I haven't done research in it. I've probably done a little bit more research than most of the people in the room, given that I'm speaking about it today. But it's an area that I have always found somewhat challenging, and an area where I think that my practice might differ from your practice, and it's an area where my practice certainly differs from guidelines. So before we start, I should have done this as a polling question, so apologies to those live streaming. How do you pronounce this? We're going to have two options, BRUE or BRUE. First, show of hands for BRUE. Show of hands for BRUE, like the heart murmur. Okay, well I'm going to go with BRUE because that was the majority. I have no idea how to pronounce it. All right, we're going to start with a case example. So once again, pull out your phones to vote. So this is little Max. Max is 5 weeks old, and Max has a past history that's got some significance in that his parents are first cousins. His mum had hypothyroidism in pregnancy. He had some initially abnormal thyroid function, but he got it rechecked and it was fine, and he has a cardiac murmur, has been referred to cardiology outpatients and is on a waiting list for that, but he's otherwise been reasonably well. But little Max has had an increase in episodes of sort of his parents describe him as finding it, he sort of coughs and finds it looks like he's struggling to get his breath, and then he turns quite pale and stiff, and then he goes floppy, and then it lasts, about 20 seconds, he froths at the mouth, and afterwards he's a bit upset. They come into emergency with this because it's increasing in frequency, and and they're worried about that. It's inconsistently related to feeds, and his parents are really worried about this. And that's not helped because when he's at triage, he has one of these episodes, and the triage nurse has him on the SATS monitor. At the time, his heart rate drops down to 80, his SATS drop to 93. She races him through into resus and grabs you as the emergency doctor. Now, you should be able to pick more than one answer. Start voting, please. I'm hoping this works. This is different to the others. You're not going to be able to cheat and see what other people say. I'm just waiting to see when this number gets to a reasonable number. I'll let you know. You can yell out questions if you want a little bit more detail. His parents are worried still. Yeah. Uh, 5 weeks. Yeah. His afebrile, his obs are normal. He examines beautifully. You notice that he does have that murmur that was described as an ejection systolic, maybe about 216, left lower sternal edge. He was term. Yeah. He's the third child. No significant other history. People are still popping votes in. That number's going wild. Some people are changing their votes because the number drops a little bit. All right, I think that's been about enough time. Where have we gone? All right, great. We've got some. So nobody's discharging him home. That's interesting. Some people are observing him with some intermittent monitoring. Some people are just bringing him in, doing absolutely no tests, but keeping him on some SATS monitor. So a really big range of events. Sorry, that's just the locked poll. You can't vote anymore. Great, thank you. So he did get admitted. He got admitted under our short stay unit. He got continuous oxygen SATs. He did get an ECG, which was normal. I have the benefit of working in a tertiary centre with cardiology on site, so we did speak to the cardiologist. They weren't interested at all, and said we're very happy with him having that outpatient echo. He doesn't need anything sooner than that. And you don't see any episodes, but does anyone want to yell out if they would give this a name, or if they'd continue to call it BRUE? Anyone want to yell out? Nobody, come on. Pardon? like a Sandifer syndrome. So Sandifer, which is sort of extreme reflux and distress. I don't know that I actually called this Sandifer. I think I thought it was maybe a bit of a laryngospasm and potentially associated with some reflux. Do I know for sure? No, but it seemed like it fit. As he's leaving, I tried to reassure the family, tried to be empathetic. As he's leaving, his parents say, yeah, okay, we're thinking about getting an apnea monitor because we're quite worried about this episode, even though you've tried to reassure us, and even those tests that you've done were normal. Should we get an apnea monitor? So grab your poll. I know that these are binary. I know life's more complex. I just want you to go for your gut in terms of whether you would discourage or support this and how you would sort of be starting to push the conversation. All right, so the vast majority say they discourage and the others say they would, nearly 90% say they discourage and 10% say they'd support. All right, so I'm going to just quickly take you, I know I don't have a lot of time, I'm going to fly you through a little bit of the literature on BRUEs, but of course, for those of you who know this, BRUEs were only, I'm not sure if I even defined it at the start, brief, resolved, unexplained events. They were called that 2 years ago. Before that, they were known as apparent life-threatening events. Now, I think it's very appropriate that the name has changed because I certainly never called them ulties in front of parents because I didn't want to tell them that it was apparently life-threatening, that their child just choked on their milk a little bit. I think one of the complexities that will come with the renaming of BRUE is you probably won't be able to even do a systematic review like this because as soon as you find a cause for a BRUE, it's not a BRUE anymore. BRUE, by definition, it's unexplained. All right, so causes of apparent life-threatening. What are the common ones that we always need to consider? Gastroesophageal reflux disease, which is essentially what I think this child had. Seizures. Seizures were surprisingly in this particular systematic review of over 600 children. Seizures came up about 10% of the time. Lower respiratory tract infections, unknown, were about 30%. Gastroesophageal reflux disease was also about 30%. But what are the zebras? What are the things you don't want to miss or that you might need to have on at the back of your mind as potential red flags? Metabolic, cardiac, and of course when a child comes in with an unusual history, even not, you should be thinking about abuse as a potential differential. So what do the guidelines tell us? Because that's what we're here to talk about. How does my practice differ from guidelines? So this was a Sentinel paper released about 2 years ago, Brief, Resolved, Unexplained Events. It was the paper that basically encouraged us all to stop using the term ulti, and I think a large majority of us have and now call them BRUEs. And what they did is they tried to give us some guidelines on low-risk babies. They tried to define low-risk babies and they tried to... high-risk babies were a little bit outside the scope of this particular paper. If you think they're high risk, you've got to think, what do you think might the differential be? And you have to investigate accordingly, obviously. So they defined low risk, over 60 days corrected, not too premature. I will challenge you on the third one, their first BRUE and no clusters. We know that in a situation where we end up thinking that this child has a laryngospasm, they often prevent, or reflux, they often present after numerous episodes, and they sometimes do have clusters. So I would say that is a very soft thing. If they have had a number of episodes, it doesn't make my alarm bells ring. Has to be less than 1 minute. Well, that's by definition a BRUE has to be less than 1 minute, so that's it. No CPR required by a trained provider. This one also, I think, challenges me. That was a consensus statement that they decided the CPR had to have been done by a trained provider because otherwise the child might not have actually required CPR. I challenge you on a few things for that. If a parent is doing chest compressions on their child and the child's not moving, they probably need it. We know that our trained providers are not great at knowing if there is an actual heart rate or not, which is why some of the guidelines have changed around, if you look lifeless rather than actually not having a pulse. So I think a good going story that the child was not, someone gave them CPR and it seemed to be warranted is where my practice is a bit different. No concerning historical features. This is the hardest. If you pull out the original paper, they then give you a list of things you should ask on history, and there are 61 questions. And they don't really put a lot of weight on what should make you concerned and what shouldn't. You have to use your clinical gestalt or knowledge to decide whether it's concerning, because they have things like increased tone or decreased tone, which is interesting to know on history, but they don't tell you whether you should be worried about one or other of those, and no concerning physical features. I've already spoken about that. And then they divide things into what you should do, what you might consider doing, and what you shouldn't do. And what you should do is you should offer education, should offer resources for CPR training. I personally find that challenging, unless you've got a free provider near you. That's tricky. I often, talk families through it. But again, you've just told them that there's nothing to worry about, and then you teach them CPR. It's a little bit... It's a bit challenging, I think. Other than the fact that all parents, it's good to know CPR, but we don't teach our asthma kids parents CPR routinely. You might consider testing for pertussis. You might consider doing an ECG, which the majority of us did in this situation, and you might consider briefly monitoring with continuous oximetry. And now remember, this is the low-risk group. If they're a low-risk child, which I would argue the child that we had in our situation was, although there were a few little red flags on history in terms of consanguinity, for example. Bloods, don't do bloods, don't do a chest x-ray, don't do an echo, don't do an EEG, don't start anti-reflux medication, and don't start anti-epileptic medication, and I agree with pretty much all of that. What they also say you shouldn't do, and which 90% of you agree with, is you shouldn't initiate home cardiorespiratory monitoring, so home apnea monitors. So I'm going to spend the rest of the time talking a little bit about why I'm going to just challenge you on that slightly in a family that's requested it. I'm not here to convince you, I'm here to just offer you a slightly alternative perspective. So I don't mean to be promoting any particular brands and models, so ignore that. But essentially these days there are 3 types of apnea monitors that are around. The Grasby's not really commercially available, but it's probably the one most of you are familiar with. It's a sticker that goes on a baby's tummy and it connects to a monitor, and you set a timer and it goes off. It's in a lot of the special care nurseries. The one to the top left and the bottom one are commercially available. So if we pretend to ourselves that our parents are not using these already, they're in baby bunting or whatever the UK equivalent is. And they're not inordinately expensive, although they're probably out of the reach of our lower income people. So the top left is a mat that goes under, detects baby's breathing in terms of the movement. You can get it with or without video monitoring. The bottom one's the newest. It's a sock that fits on and it checks your pulse and your oxygen sats, and it reports to a parent's phone. Now, when I was training, I was taught this, and this is probably why most of you have said, no, you wouldn't encourage it, that they false alarm, that they increase anxiety, and that they don't change outcomes. And I should have added to this slide, and in addition, these children are not at increased risk. There's very little evidence that these children are at increased risk of going on to have a SIDS or SUDI event, which of course is what we're all worried about when we're talking about apnea monitors. Now that didn't always sit well with me in training, because I agree with the top one, they do falsely alarm. I agree with the bottom one, there's no evidence that they change outcomes, but someone tell me how you design a study that showed that an apnea monitor reduced SIDS. Please do, tweet it. It's going to be hard. I've got some ideas, but I won't go into them today. Tweet me if you've got an idea. We can't do it. There are too many confounders, and the rate of SIDS is just so low. But I essentially, let's say I agree with that. Doesn't change outcomes and it false alarms. It's the middle one that I will challenge you on, this increasing anxiety. Because to me, when I was training, that always sounded a little bit paternalistic or patronising to families, where they'd say, should I have an apnea monitor? I'm really worried about my child. And we would say, no, don't worry, I'll just make you more stressed. Don't Forget the Bubbles is all about journeys and We often hear emotionally challenging things in Don't Forget the Bubble, so I'm going to briefly take you on my journey and where my personal practice got affected in the use of apnea monitors, and I'll try and do it without my voice shaking too much. So this is Jack, who is my first boy, but he's not my first child. So my first child died soon after birth, not from SIDS or SUDI. But when Jack was born, I was really anxious. You know, pregnancy had been awful. She died of birth-related complications, and it was awful. And I was sitting there on the second day or third day, full of all the hormones and all of the emotions, and his paediatrician, who was also Sophie's paediatrician, walked in and said, how is he? How did he sleep? And I said, he slept really well, but I didn't sleep. And she looked at me and she could have said to me what I already knew. I knew he wasn't at high risk. I knew that almost certainly he wouldn't die of SIDS or SUDI. I knew the chances were really low. The chances of Sophie dying had been really low too, though, and I'd already been that 1 in 8,000, you know. So instead of telling me everything that I already knew, she looked at me and said, do you need an apnea monitor? And that was it. I was like floods of tears and all the emotions and all of the hormones. But I used one for him, and I used one for the rest of my boys, and I had already questioned this mantra, but then I came back to paediatrics. I qualified sort of in the time that I was having kids, and I came back and started looking at families who were then again asking me this question, should we use an apnea monitor? Now, 1 second while I blow my nose after that emotional story. So my story might be compelling, but we are doctors, okay? Mine is an N equals 1. You know, I was anxious. She could have told me, you know, to see a psychologist about it. But, you know, you should not be influenced by that question, by my example. But what it did do was make me go and look at the literature for anxiety. Because, again, I completely agree that it false alarms, although the Grasby that used to come off used to false alarm all the time. The pad false alarmed once in 12 months. I agree that it doesn't change outcomes, but can we prove that it increases anxiety? I'm actually going to go back 1 step to, can we prove that that it doesn't increase SIDS? There is one paper of 1,000 children, high risk for SIDS, low risk for SIDS, and they put apnea monitors on all of them. They did that because they wanted to, well, what they ended up finding was that normal children have a lot of apneas, as do the high-risk ones. Within that study of 1,000 children, 6 children did die. None of them were on their apnea monitor at the time. Can we prove, so what am I talking about? Can we prove that apnea monitors increase anxiety? I've dug through the literature in a lot of detail, and we can't. There are studies that show that it does, but they're very flawed because the apnea monitors were given or sought out by people who had a reason to, like me. Because if you'd interviewed me at the one month mark and asked me if I was anxious, I probably was. So they're flawed, they're not controlled. One of the best studies looked at children who were given monitors. One of them got education about the monitor and the other group didn't. Both groups had a reduction in anxiety. These were all high-risk children. They all had a reduction in anxiety, but the group that got the education had a greater reduction in anxiety. And there are plenty of studies that show a reduction in anxiety. There's one of 47,000 children that show a reduction in anxiety, but that's done by one of the companies that manufactures the alarms, and I haven't seen the protocol, so I would argue not to use that. So what do I do? What do I do in that situation from before, that when 90% of you said you'd discourage the apnea monitor when the stressed family is asking for it, what do I do? Well, the first thing I do is I talk about safe sleeping, because that is shown to change outcomes. Does anyone know who this is? Oh, love it. The Melbourne girls in the front row know that this is Kim Kardashian and Kanye West's son. And they tweeted this image with all of the bad safe sleep practices to their millions upon millions of followers. So, I mean, I won't get you to point out all of the followers because I know all of the issues because I know we're tight on time. But I talk to families about safe sleep. I do explain to them that if they choose to use an apnea monitor, that it will not It has not been shown to change outcomes with SIDS and SUDI. And I do that for a few reasons. One is that I don't want to be falsely promoting something that is expensive. And the other reason is I know lots of families won't be able to afford an apnea monitor, and I don't want them to feel like they're doing less by their child by not having one. So I explain those two things. I talk them through false alarms, and I think this is one of the most important things. I, like probably all of you, have seen babies come to the emergency department just because their alarm sounded. And what you need to explain to families is the alarm will go off. It will. And when it goes off, your child is probably just fine. So go and have a look at them, check on them. I also tell them what to do if they go in and their child doesn't look fine. And I keep it pretty basic. I'm not doing full CPR for the reasons of CPR training, but I give them a little bit of the basics. But the most important thing that I think I tell them is don't shake your baby. Because I think the natural instinct of a parent who goes in and they genuinely think their child is dead is to say, wake up. So I make that very clear to families. So I hope that I've just given you a few, challenged you somewhat in an area where I think families need a lot of support. I think BRUEs are a little bit like febrile convulsions. We're very nonchalant about them because we see them all the time. But in that moment, the parent genuinely thought that their child was going to die. And I think we can't underestimate the impact that has. I'm like a detective with BRUEs. I think everything is in the history and really digging deeply into the history to try and understand what it is. And beyond that, in a family that asks me and who is distressed about the use and wondering about the use of apnea monitors, I think that it can be, with appropriate caveats, a useful tool to help parents. So hopefully all three of us have shown you today that guidelines are exactly that. They're guidelines. And they're really, really helpful, but we also have to apply our professional experience, and we can't help but apply our lived personal experience to influence us. Thank you.
Thank you so much, Sarah, and thanks for sharing a very personal story as well.
Thank you.
I'm going to give you a minute.
Right.
Are there any questions for the other two on the panel? Just to give Sarah a little,
I'm okay.
little break. You're okay?
Yeah.
Okay, fine. Any questions for Sarah? Or anything from Twitter?
There were no questions, but there are a few people that thanked you for sharing your story.
Thank you.
I still think it's BRUE.
Yeah, there's one over there, thanks.
Yeah.
Oh, wow, hello. I think one of the biggest challenges we face is when we have those anxious parents and we're not anxious and they're clearly very anxious. How do we, and this is for everyone, for everything, not necessarily for BRUEs, how do you stop them being anxious? Like this always comes up, but how do you stop them being anxious?
I think it's really difficult. I think having the empathy and acknowledging the anxiety is really important. I love something that Damien said on Twitter once, I think I'm crediting you appropriately, is that observation is an investigation in paediatrics. And we are all under pressure with, I head up our short stay department, it's all about flow in the hospital, but sometimes you do have to take a step back for the family in front of you. And if observation with really clear guidelines about what you're looking for and what the purpose of that brief admission is, I think that can be really helpful. And a close follow-up as well. But part of it is having the confidence yourself, because none of us like to sit, I personally don't like to sit with uncertainty. It's the hardest part of the job, but it's a huge part of our job. And that unexplained in the BRUE title is hard for many of us, I think.
There's a what and a why. So, is that what's working? You've got the what, and you've described this thing where you're not concerned, but the parents are. But it's actually a grid. So you've got the doctors or clinicians concerned and parents are concerned. If neither of them are concerned, that's fine. You got it. If you're both concerned, you're on the same. There are times when the parent's not concerned, but you are, and then you've got a kind of a safeguarding or maybe social factors, and then we're left with probably the hottest potato, which is where there's a dissonance of concern. And then I think that the big thing is being very clear about why you're anxious. And you sometimes need to spell it out or ask the same question in different ways. My experience is there often is an underlying reason. But sometimes, and I think if you imagine you'd had something happen to you that you were maybe a bit embarrassed about or you didn't want to reveal, you might not reveal that at the first occasion. It may well be that there's a family member who has died. There may be a really silly story, something that is completely innocuous that you've read in the news. My experience is that the families also at a time of life in the child where postnatal depression is relatively more prevalent. We are absolutely rubbish generally at picking that up and acknowledging it, especially in the emergency department. And the anxiety might be out of proportion. If we're not willing to spend a bit of time understanding that, then we're going to run into difficulty. But as I said, we don't have time. It's not easy to spend 25 minutes in a cubicle on a busy Sunday evening at 10 o'clock with one family. And that's a conundrum I can't solve. But I think we have to acknowledge that is part of the problem.
I think Twitter's firing up with questions now. Becky?
We've had a question come through from Rob Stillman. He says, a common theme is achieving acceptable risk of unacceptable events, like sepsis and SUDI, and how subjective defining this acceptable risk is. Are we spending too much time trying to find tools to stratify risk and not enough having the conversation about what level of risk we are actually trying to achieve? We sometimes talk about it as if it should be zero.
I think it's exactly the same applies for sepsis as well, and for lots of things we do in medicine. I often talk about these things are really bad because they've caused a click and collect culture in healthcare now. So I can pick up my phone, I can do my banking, book my holiday, book my shopping, deal with the entire of my life instantly. The one thing you can't do instantly is sort out healthcare. And we have a generation of the public and ourselves who are used to doing things rapidly and want an answer and want certainty. This is the one area we can't give certainty. And being comfortable with uncertainty is, I think, the healthcare professionals aren't particularly good with. And if we're not good with it, the public certainly aren't. We need to do a lot more to improve that.
And I think when the uncertainty, as you say, when it's so extreme, I mean, what every parent of a child who's had a BRUE wants to hear is that their child won't die of SIDS or SUDI. Now, you know, my son, you know, I knew he was at absolutely no increased risk compared with the general population, but the risk wasn't zero, and I wanted, you know, that was really obviously playing on my mind. And we can't look at families and say, no, your child is not going to die of SIDS or SUDI. You can say, no, your child doesn't have an increased risk of dying of it. But that to parents, what does that sound like? So I don't actually know what the correct answer is. Yeah.
Any more questions from Twitter?
Says, as seniors we are told, oh, it's from David Sinton, as seniors we are told the guidelines are guidelines and we can deviate, but if things go wrong, we will personally be held accountable for that deviation, particularly in relation to national guidelines. So how do you, with deviation in practice and personal?
I mean, I personally document it so that my practice is that I write a clear statement of this child has this features. My personal belief is this is the underlying reason and this is why I am doing this.
I don't think, I don't think any of us are advocating to just willy-nilly go ignoring guidelines. Guidelines are important for many reasons, and we know that reduction in variation in care can actually improve outcomes as well. But what I think we're all asking you for is to look at the individual child in front of you, and if there's a valid reason to go against the guidelines, or if you've interrogated the evidence and you think that it doesn't apply to the child in front of you, then again, document your reasons and speak to a senior.
Yeah, the senior thing's important. I think there's a weight that I think a senior is allowed to have that level of experience and make a decision where that weight of responsibility might not be afforded to a more junior doctor. My personal belief is thinking through that process is healthy in its own right. The very fact that I think I might be going off guideline forces me to think about the particular process which is likely to reduce any cognitive biases that I have. It's the moment you don't think you're doing that where the problems arise.
100%.
Wonderful. Thank you. It's been so good to spend this time thinking about these grey areas of our practice. Please join me in thanking our three speakers, Damien, Meredith and Sarah.